Thank you very much. Thank you for the kind introduction, and thank you, Dr. Long, for the invitation to be here. I'm falling in love with Hong Kong, and it's a lovely conference. Professor Yaron's talk reminded me of the moment in which I went through genetic counseling for my own pregnancy. And when I told the genetic counselor that I'm an Ashkenazi Jew, she took a deep sigh, rolled her eyes, and picked up a form with all the conditions that she thought she had to talk to me about. And then she thought about it and said, wait, but your husband, is he also Ashkenazi Jewish? And I said, no, he's Irish. And she said, yeah, and threw away the form. So that was very funny. I am now between you and lunch, which is a really tough spot to be. So I'll try to keep time and keep you interested. It's not a disclosure, but for information, I'm a part of a big Canadian team that runs currently, or just finished, a big study about the implementation of NIPT in Canada. And so I would like to speak about the specific challenges that NIPT raises for ethics, for social concerns. But, you know, I don't like when ethics is framed and perceived as focusing only on concerns, on issues, on difficulties, and on barriers. So I'd like to start with the benefits. And just the last point that Professor Yuval made, sometimes not doing something is an ethical issue. Ethics is not always just about telling us what not to do. And once again, I'd like to share the story of my own pregnancy. When I was pregnant at 40 and my integrated screening test came back with a very high risk, I did want to know more information about my fetus, but I did not want amniocentesis. And the fear of losing a very precious pregnancy, especially for older women, when they're not sure that they will be able to conceive again, the concern about this risk of miscarriage is huge. And when Professor Lowe talked about, as a medical student, thinking to himself, really, there's no better way of doing this than sticking needles into pregnant women's bellies and creating a risk. That really resonated with my experience and with the concerns that I hear from so many pregnant women. So when I first heard about NIPT, I have to tell you, I stayed up all night, very, very excited, and I wrote a short article, and the title of it is NIPT, an Ethical Imperative. And the argument of the paper was that if we have this technology, we have to implement it immediately, because it's solving a dilemma that pregnant women have been facing for so many years regarding agreeing to take a risk of miscarriage in order to have access to information about their fetus. So the benefits of NIPT are clear, they're immediate, and I'd like to share with you, at least in Canada, the immediate benefits that we see as we implement NIPT. So in Canada, every year, about 500,000 women become pregnant, and many of them will undergo traditional screening. If it's integrated, 2 blood tests and an ultrasound to give a risk number. And then of about 315,000 screening tests, about 10,000 will make the decision to undergo amniocentesis, and this will discover about 70 it will discover about 270 trisomy 21s at a cost of 70 unaffected fetal losses. And these numbers are not great. Each of those fetal losses is very tragic for the family. So where is NIPT right now, and I think that's similar to other countries, is as a second-tier screening test where of those who get the high-risk result, women can choose to do NIPT in order to decide potentially not to go on with amniocentesis. So if the NIPT result comes back reassuring, many women will say, okay, this is good enough for me, I'm not going to pursue invasive testing. And we already see the reduction from 10,000 a year to 300 amniocentesis a year, almost the same rate of detection of trisomy 21 with 1 miscarriage. So this benefit is here now. We're seeing it all over the world with the introduction of NIPT as a second-tier test. But we're now moving slowly towards thinking about implementing it as a first-tier test. What would it mean for numbers? We don't know yet. Studies are ongoing. But it definitely means that we can have the results earlier in the pregnancy, potentially even at 11 weeks, definitely in the first trimester, because we won't have to wait for the results of traditional screening tests in order to decide who gets to do NIPT. So this is the same benefits as before, plus earlier in the pregnancy for the results of NIPT. And maybe someday, who knows, right now this is a screening test. We tell all women, all professional societies emphasize it has to be confirmed with invasive testing, but maybe someday it will become diagnostic for certain conditions, and then the benefits are, of course, even more pronounced with earlier results and completely avoiding the need for invasive testing. So maybe this is the future of prenatal testing. So the benefits, it's safe, no increased risk of miscarriage, more reliable than current serum or integrated screening tests. Results are earlier in the pregnancy as soon as we move to first tier. It could be cheaper than the current testing pathway, depending on how it's implemented. And as we heard this morning, it allows testing for a growing number of conditions. So it's not surprising that empirical studies around the world where women were surveyed about their attitudes about NIPT shows that women are very enthusiastic about this technology. They're paying for it out of pocket, hundreds of dollars right now around the world. And once it becomes integrated into healthcare systems and publicly funded, which is already the case in some countries, the expected uptake is very high. So what are the concerns? What issues does NIPT raise? And I want to share with you from the literature and from our study in Canada 5 groups of ethical and social and legal concerns. If we have enough time, I'm not going to delay lunch, but if we have time, we'll even talk about the future possibility of whole genome sequencing through NIPT. But definitely, let's focus on the more actual present concerns. And first of all, the issue of justice and equity. So the cost of NIPT came down since 2015 from, I know, around $2,500 to now about $600 or even less. But in some countries and for some couples, this cost is still a barrier to access. And that leads to inequity in the offer of the test in the sense that women who do not have the resources to pay out of pocket a few $100s may opt for invasive testing because that is often covered by public funding or insurance. So amniocentesis is covered in many, many countries. And that means that women without resources have to subject their pregnancies to the risk of miscarriage that can be mitigated by NIPT. So that means that, for example, when we surveyed Canadian women, they saw this as a major issue of justice because Canadian women live under universal health care and they're used to all their medical needs being paid for by the government. When somebody told them there's a good test that you could benefit from, but it will cost you $600, they were outraged by this. They thought it was the end of the world. So many governments are currently struggling with how to implement NIPT within the public healthcare system. Many European countries cover it. In Canada, 2 provinces cover it. In the US, many insurance companies cover it. But most cover it only for high-risk pregnancies. So you have to go through the traditional screening test first, and if you get a high-risk result, then your NIPT will be covered. I'd just like to say that policy decisions should be evidence-based. So the RAPID study in the UK, our Pegasus study in Canada, everybody's looking for that magic number of at what level of risk would it be cost-effective to cover NIPT. Is it 1 in 1,000, 1 in 500? At the same time, most women want NIPT, even if their risk is lower. So issues of justice on one hand and access and issues of cost effectiveness for the healthcare system on the other, I think this is something we'll be struggling with in the coming years, and robust studies that look at the implementation from the perspective of for what populations NIPT should be paid for by public money, these studies are crucial. There are also concerns in the literature about premature implementation due to commercial pressures. So the market for NIPT worldwide is billions and billions, and it's increasing and it's exploding. And companies have been accused of presenting the results, the reliability of the tests that they're selling as too reliable, over-promising the performance of the technology because of commercial interests. This is a concern because women who buy this privately, what they get is the brochures from the companies. You know, the performance of the test is a statistical. Numbers can be presented in many ways and have different psychological impact. So I think, again, as researchers, we need to really pay attention to how we present the information and be aware of the commercial push to move, for example, from second-tier screen to first-tier screen, because the market, if we offer this to all pregnant women, even low risk, the market is substantially bigger. So that's another concern to keep in mind, this commercial pressure to implement the technology. And this is a paper that we published out of the Pegasus study that we called Unveiling an Impaired Translation Process. And it looks precisely at how the pressures to implement NIPT impair the way that it is offered. The second concern, again, as a past pregnant woman, to me, that's a set of concerns that we should all think about every day. Routinization of a new technology is, of course, the greatest success of the technology, but routine use can create an expectation of uptake. It could entail increased pressure on women to test, especially in the absence of risk of miscarriage. And that could create a threat to women's free choice, or what we call in the ethics literature, reproductive autonomy. We need to ensure that women are offered NIPT and that they understand that they have the choice to accept it or decline it. Now, what's interesting, when we look at the history of prenatal screening over the last decades, the only place where informed consent really held its ground was prior to invasive testing, prior to amniocentesis and CVS. Why? Of course, because if you put a pregnancy at risk, you have to make sure a woman understands the nature of the test, signs a form, that you're covered as a clinician, and that if there's, unfortunately, fetal loss, she knew that the risk she was taking. But let's look at ultrasound. We heard a great talk. Do women give consent to ultrasound today? No, we completely abandoned the notion of counseling and consent before ultrasound. It's not invasive, there's no risk, it's completely routine. What about current screening tests, serum screening? Yes, in some countries there are forms to sign. Physicians are supposed to counsel women before the test, but in reality it hardly happens, and most women who are surveyed don't remember that they heard any information about screening before taking the test. When they get high-risk results, then they realize that the test happened. Is that how we want to implement NIPT? Completely routine with no counseling, considering that the information is borderline diagnostic for some cases. So that's a major concern. We also have to make sure that the choice of NIPT is informed. The framing of testing as ensuring the health of my baby is ethically very problematic. So the literature shows us that many women believe that testing somehow promotes the birth of a healthy child, such that a caring woman is not doing her motherly duty if she refuses testing. And that means that prenatal testing has become a ritual of reassurance. Refusing the test can sometimes be perceived as medically irresponsible and even unacceptable. But we have to remember that prenatal testing, NIPT or otherwise, does not ensure a healthy baby. Women need to get appropriate pre-test information to understand the meaning of the test and their options following testing. And the options are prepare for the health of a child with a specific problem, or terminate the pregnancy. But for almost everything that we test prenatally, we do not offer prenatal treatment or a cure to the fetus. So women have to make informed choices. And that leads me to, I don't know if you've been following, but in the UK, just a couple of weeks ago, a paper came out about a new way of offering NIPT that is called reflex testing. Anybody heard of that? So they were basically taking 2 blood samples, the traditional screening and an extra one, and if the regular screen came back high, they automatically sent the second one to NIPT without ever giving the woman her high-risk result from the regular screening test. And their argument was, oh, why create anxiety if we can just wait for the NIPT results and give them better information? But all women got prior to this was a brochure, a pamphlet. Nobody actually talked to them about this. So there's a real risk of women not being informed about this test until the results come back. And indeed, some studies with healthcare providers showed that in the absence of risk of miscarriage, they thought that informed consent is much less important for the test. So is this what we want? And I'm asking it a little bit as a rhetorical question, but considering the reality on the ground also is a real question. Do we agree to implement NIPT without counseling and without consent to the test? Something that we need to keep in mind. And lastly, decision-making has to be supported, especially as NIPT shifts to becoming a first-year screening test. As I said, it will shift from being offered to a relatively small high-risk population to all pregnant women. And if we take the US as an example, it means moving from about 100,000 tests a year to about 3 million. And obviously, the healthcare system will not be able to offer traditional genetic counseling to these numbers. So I reiterate what was said by previous speakers. We need to rethink or reinvent our models of genetic counseling. We have to support and train OB-GYNs and GPs who are actually going to be offering NIPT. And we have to create innovative educational resources for women and for professionals. We have to encourage shared decision-making. Many women don't want to just be given information and go home to think on their own. They want to discuss it with their healthcare provider. They want guidance. And there's a thing called a decision aid tools, which is sort of a series of forms to guide the conversation between the woman and her clinician, and to integrate also issues of values, not just statistical information and clinical facts, but also values. What matters to you? What cultural values do you bring to the pregnancy, to having your children? What resources does your family have? So allowing women to discuss, to have a more holistic discussion with their healthcare providers is very important. And finally, the legal concern about offering NIPT. At what point could a woman come back after having a child with a problem and potentially sue a healthcare professional for not offering NIPT when she was pregnant? So this is called wrongful life claims, where a woman actually sues a doctor for having had the child that she had, claiming that she now needs to be compensated for the medical expenses. So again, from the Pegasus study, we published this legal analysis that shows that indeed there hasn't been yet a case based on NIPT, but there could be legal grounds for patients to sue if they were not offered NIPT. And this brings us to the issue that Professor Lowe discussed about maternal cancer. Could we see such lawsuits of women who discover cancer later on and say, I did NIPT, how come I was not provided these results that could have given me earlier diagnosis or even saved my life? So again, as clinicians, this raises concerns. At what point do we have to offer, not just have the choice to offer? So decision-making has to be free, voluntary, and informed, but it also has to be supported both for women in terms of counseling and guidance, and for clinicians who need the training, and their concerns about possible litigation need to be addressed. I'm moving on to concerns about disability rights and eugenics, and this started to emerge with the last question. So the famous disability rights critique of prenatal testing puts before us what has been called the expressivist argument. And this is a good quote. Prenatal tests to select against disabling traits express a hurtful attitude about and send a hurtful message to people who live with those same traits. So when we target trisomy 21, as we have been in all countries, many families raising children with Down syndrome feel that this stigmatizes their children, their families, that they're seen in society as raising children that we choose not to even have. And NIPT, as it enters the healthcare system, raises concerns that with increase in testing and in detection, there will be increase in terminations. Already today, based on testing technologies that we have, we're told that 80 to 90% of pregnancies diagnosed with trisomy 21 are terminated. And the issue is, as the population of individuals with Down syndrome decreases, will that affect the support that their families get and research on their condition? So this is a story about a neurologist who had a daughter with Down syndrome and started doing research about using antidepressants to improve the cognitive function of children with Down syndrome. There's a lot that we could do to improve quality of life, to improve cognitive function, and of course to integrate children into the educational system and into the job market. Will we do these things when there are very few kids with a condition? And the same question can be asked not just about Down syndrome, but about other conditions as well. And overall, as society becomes less diverse, as we're screening out more and more conditions before conception, PGD, prenatally, are we going to become a less tolerant society? Will we increase the expectation of everybody having perfect babies? Will we see stigmatization of women and couples who choose to pursue a pregnancy knowing that their fetus is affected? And we're seeing now in the US, couples feeling very judged if they had Down syndrome diagnosis and decided to pursue the pregnancy. They feel in their follow-up prenatal visits that the healthcare providers are sending them a very hurtful message, to the point that some clinics opened specifically to follow up pregnancies with Down syndrome, which I find really interesting. I recently gave a talk in a clinical conference, and after my talk, during the coffee break, a nurse came to talk to me. And she said, only yesterday in the ER, we admitted a young child who was in pretty bad shape. He needed dialysis. And as they were accepting the child, I heard the doctor say to the parents, what your baby has could have been detected prenatally. You didn't do the tests? And of course, the tone, the messages, almost of a blame and definitely of a responsibility. Why did you have a child with a problem that now, well, A, suffers, and B, that we all have to pay for when you had access to prenatal tests? So this issue of stigmatization is real, and we have to pay attention. Even going as far as possibly penalizing parents who choose to have, either reject testing or choose to pursue pregnancy by loss of medical insurance for those conditions that could have been detected prenatally. Now, in countries with universal health care, that's not a problem, but in a place like the US, where everybody's talking about what is considered to be a pre-existing condition, what's stopping us from saying that what we could detect prenatally is pre-existing already at birth? And that has been a concern for many years. It hasn't happened, but again, something to keep in mind. Threshold of testing. As we heard, with invasive testing, because of the risk of miscarriage, we only test for what we consider to be serious or severe. But the risk-free nature of NIPT plus the ability to test earlier could lead to lowering the threshold. So parents may wish to look at severe or less severe or treatable conditions, late onset conditions, breast cancer, Huntington, and even physical traits, or in the future, who knows, behavioral or personality traits, and non-medical information such as paternity and fetal sex. We ran a survey in Canada of hundreds of pregnant women, and they were very interested in using NIPT for paternity. Interesting. Fetal sex, already in 2011, there was this paper was published in JAMA with a meta-analysis showing that NIPT for sex is, of course, completely reliable. And here's a direct-to-consumer company called Pink or Blue citing this paper to sell couples very early sex determination, and they even call it gender test. And look how they sell this. Standing in the baby aisle, wouldn't it be nice to know whether to choose the pink blanket instead of settling for the generic green? So, of course, knowing the sex of your baby is only about the color of the blanket. It's about how to decorate the room. And indeed, in some countries, it's just a preference or used for family balancing. So if you already have 3 boys and you really want a girl for the 3rd time. But, of course, in other countries, there are cultural issues and cultural pressures to have boys and not girls. And prenatal testing plus selective termination already created a social reality where the natural sex balance in society is skewed, and there are severe social issues as a result. Young men don't have wives. It creates social unrest. It has increased the violence against women in some Indian cities. So we already see the outcome of the combination of this technology with cultural pressures regarding sex selection. So it's not all about the color of the blanket. Sometimes it could be about other issues that can lead to serious social problems. I'm out of time, so I'll just say about whole genome use of NIPT that we have to seriously think about what to do with this possibility. Permit it, limit it, encourage it, cover it. It raises a host of ethical issues about how reliable is the information, who will have access to it, and a concern we haven't talked about, the right of the child to an open future. If we run whole genome sequencing through NIPT and then pursue the pregnancy, a child is born with their entire genome known to their parents and potentially to clinicians and to society. So what does that do to the notion of genetic privacy and genetic discrimination? Huge issue to consider as we move ahead. And of course, we have this notion that knowledge is power, and the more knowledge we give pregnant women and couples, the better their decision making. But sometimes, not all information is knowledge, and sometimes knowledge can be vulnerability and not just power, in the sense that women have a very short period of time to make decisions, and if you just burden them with tons of information, much of which is not reliable or the significance is not clear, how are they going to cope with it, with the anxiety, with the confusion, and once they make the decision, with possible guilt and decisional regret? So we wrote this paper arguing that providing unrestricted access to whole genome through NIPT does not necessarily translate to enhanced autonomy or to better decision making. And I want to finish with this reflection into the future. Ultrasound made the uterus transparent. It revolutionized our perception of the fetus, right? We expect to see the fetus before birth. We have pictures to send family and friends, and 3-dimensional ultrasound actually allows us to sort of meet the baby before birth. If we move ahead with NIPT all the way to whole genome, it might create sort of a cultural expectation that the fetus itself should become transparent. Maybe parents in the first trimester of pregnancy will expect to know the entire genome of their fetus in order to make a decision about bringing this child into the world or not. And this reminds me, of course, of the film Gattaca that maybe many of you have seen, about a society where people have to really pass a certain threshold in order to be admitted into society. And I think we're facing very challenging ethical issues about the children we choose to have and how our individual choices shape the face of society, and our level of tolerance for difference and our support for families who make various types of decisions for their own individual reasons and also based on their cultural and religious values. So how to protect our compassion, our tolerance, how to protect the freedom of choice of women and families. These are things that these new technologies raise issues about, and I'm happy to discuss. Thank you.